Good evening. For those of you out there, welcome to tonight's Facebook Live. Tonight we're going to spend some time focusing on the use of donor gametes, the use of donor embryos, and possibly the smaller group of those women that are desiring surrogacy. So welcome again. My name is Scott Salisbury. I'm a fertility specialist with QFG and have been so for over 25 years. So hopefully I'll bring some grey hair and wisdom to the evening. And I welcome you all to fire as many questions as you can to me. Just be kind to me. It's late at night and make the questions easy for me. But feel free to ask whatever you like, and we'll chat through those. I'll try and answer your questions in the context of the discussion I have initially around the topic. Now, the other little issue is we may have a little trouble with the feed for the questions, and they'll be coming to me by phone. So I apologise if I look down to my phone. It's not that I'm suddenly answering my daughter's text, which he does about a million times a day. I'm really looking to see what the questions are, so please tolerate me with that respect to that. I thought I'd start the evening with some discussion around surrogacy. I'll start with the least common and probably work our way through the scenario with donor gametes. Now, from that point of view, I thought I'd spend a little bit of time talking about surrogacy. Surrogacy is a difficult decision for all because it's the most complex of all the arrangements I'm going to talk about tonight. And often surrogacy is achieved after many years of trying for pregnancy. Obviously, in an ideal world, people conceive in their own homes at home, and there's obviously a progression into being worried about that and having investigations and then moving on to assisted reproduction, whether that be using timing or drugs or insemination or indeed IVF. And it's only with recurrent failure sometimes that we then are able to achieve an objective by saying that realistically you can't carry your own pregnancy. And so from that point of view, surrogacy, or the topic of surrogacy, is introduced. So that's not always the case. I mean, some women know from the very onset that they're born without a uterus, for instance. And so from that point of view, they know from a young girl that the only way they can have a child that's biologically theirs is when they have another person to carry their pregnancy. And obviously that's heartbreaking for them when they're young. And there are many other scenarios other than that. I mean, sometimes the uterus is removed because of cancer or because of large fibroids or other medical problems that make it necessary to remove the uterus. Sometimes we discover during the course of IVF that a uterus is unusable. The endometrium doesn't proliferate. It doesn't get thick enough. And they're a fairly common group that we see nowadays because of the multiple surgeries that people can have in their uterus. Equally, there is a number of women that have severe medical problems that in the past we would have told that they couldn't have a pregnancy, or indeed if they did have pregnancy, they'd run a very high chance of dying. These are some of the major cardiac abnormalities or some of the respiratory conditions that where they have such diminished lung function that they would actually probably perish in pregnancy. And there are some conditions where, because of their medical conditions, they need to take heavy-duty drugs that are contraindicated in pregnancy, but to come off those significantly shortens their lifespan. So there's a lot of complex issues in those. And there's also the smaller subgroup of social surrogacy where, for instance, same-sex male couples can access an egg donor and a surrogate to carry their future pregnancy. So from that point of view, it takes a lot of work to get to the stage of viewing a surrogate. And I'll make it clear from the outset, as is true of most donor gametes, that surrogacy is not a commercial transaction in Australia, which differs to many countries throughout the world where surrogates can be paid to carry your pregnancy. Unfortunately, in Australia, it's not. That's not allowed and strictly written into the Act that it's punishable by terms of in jail, for instance. So you need to be very careful when seeking out a surrogate. The surrogate can be reimbursed for reasonable medical expenses, but at the end of the day, that would be looked at quite closely. So the principle is quite simple. Someone out of the very goodness of their heart is designed to act as a surrogate, and these are salt-of-the-earth people that the ladies I've had are marvellous people that are willing to give up 9 months of their life to carry a pregnancy for someone else. It's a marvellous act, and I can only take my hat off to them many times. So the intended parents, which are usually the biological parents, so they're They're the creation of the egg and the sperm in an embryo through an IVF process, then creates an embryo which we then transplant into the surrogate for a successful pregnancy. Now, in Queensland, Queensland was a bit slow to the movement in terms of legalising it, and so it was only until a dozen or so years ago that surrogacy became legalised in Queensland. And the Act leaves it very open. So in other words, there's the ability for most couples to use surrogate. The Act hasn't been very restrictive, although there are some minor restrictions. Having said that, at the Queensland Fertility Group, we've opted to impose a number of guidelines that restrict the use of surrogacy to everyone. And really that's just based on the process of sorry, I'm distracted by the phone already. That's really once the embryo is placed in the surrogate. Sorry, I've lost my train of thought there. The process within QFG is to see a fertility specialist. Having reached the stage of wanting a surrogate, you will explain the intricacies of the process, and I'll touch on some of those issues. The other issues relate to the surrogate being appropriate, and obviously they need to be of sound mind. They need to have good reproductive capacity, in so much as that we impose the restriction that all our surrogates must have had children before. And that then sends a clear path to reduce the risk of pregnancy, because pregnancy is a very high risk status, and people still die today in childbirth of various causes. So we want to be sure that because of their previous experience, their risk is low. They obviously had to be void of any significant medical illnesses as well. So from that perspective, they're tightly screened, and obviously the surrogate has to agree to a number of conditions. The other really important thing to realise about surrogates in Australia is that they remain the legal parent of the child when the child is born. That's a very difficult concept to get across, because in many countries like the States, it's written into a legal contract that they must give up the child at the end of the pregnancy. That's not the case in Australia. They remain the legal parent. And in fact, what happens is the intended parents need to apply to the courts after the child is born to obtain legal custody. And in Queensland, as far as I'm aware, that's never been a problem. But I guess it comes to the fact that there's a very tight screening process for how that may come about. And by that, I mean, what happens is once a couple decide on a surrogate and they move forward with that, then they then screen by a committee within QFG to make sure they satisfy our criteria. And once the committee has given approval for that, that's when we let the couples go and explore their legal ramifications and the psychological counselling that's so important. Because of that ramification of the surrogate being the legal parent, it's very important that you're comfortable with your choice of surrogate. And all sorts of things will be discovered in the surrogacy process. Some of those relate to who's going to be present at birth, what decisions are made around screening for abnormalities, should you take out life insurance, should they be privately insured, what provisions have you got for looking after existing children. And they're all things that need to be explored. And if ever I've been involved in a surrogacy that's gone a little bit south of, as time's gone by, it's because they haven't had adequate communication. And that's what the importance of the legal process and indeed the psychological counselling, which is seen both independently and together. Once that's done and a surrogacy agreement's struck between the intended parents and the surrogate, then we'd move forward with final approval from the committee. And once that's given, then they can proceed with whatever methods they've had. I've already had a question asking about the difference between traditional and gestational surrogacy. In a traditional sense, what people usually refer to is where this is where sperm is used to inseminate the surrogate, so utilising her own eggs to try and fall pregnant, just like a heterosexual couple would do. That's fraught with some concerns, because the surrogate then is the owner, if you like, in inverted commas, of the eggs, and that, in my opinion, leads to a slightly higher chance of her wanting to retain the pregnancy because it is biologically hers. Obviously, that's done in same-sex male couples, and we do try and avoid that with intended parents as well, just so the biological mother, so the intended mother can be the biological mother as well. All other forms of surrogacy involve the process of IVF, where embryos are created in advance and then placed in the surrogate. So I thought I'd touch on that, and certainly if you have any questions about that, please don't hesitate to throw them through. I then thought I'd move on to the issue of the more common scenario, and that's of sperm donation. Sperm donation obviously is fairly commonplace, and it's the oldest treatment we have. It's probably been going in Queensland for over 50 years. Once upon a time, we had a very robust sperm bank, and we used to actively recruit donors in Australia through university students, through armed forces, etc., or people that have heard by word of mouth. And certainly you could advertise quite freely about sperm donors. And sorry, I apologise again for looking down at the questions. Now, I guess sperm donors are traditionally used for men with no sperm, or men with very poor sperm that create very poor quality embryos with IVF. Some men possess genetic disorders that they don't want to pass on to their offspring. But of course, with modern day IVF and the ability to screen embryos, there's a lesser need to go straight to donor sperm for those men that carry a genetic condition, because we can screen those in the embryos before we put them back in. And I guess the other big group that we now use donor sperm with is the same-sex couples, or indeed the single ladies that desire a baby. And that's probably the biggest group that we use donor sperm from. Now in Queensland, which is again different from state to state, but Queensland has what we call a 10-family limit, meaning that 10 families can be created from the same donor. And that's obviously undertaken to try and minimise the chance contact of siblings in a relationship. Our sperm can either be derived from Australian-based donors. Unfortunately, they've become less common through changes in the guidelines, where we now must make all donors undergo counselling, and the process would be that they would see a doctor within QFG. They would undergo appropriate counselling so they understand the implication of donating sperm. They would then have an extensive family history, and they would also then have an infectious screen and a genetic screen looking at very common recessive conditions. And there's already been a question about screening for egg donors, but the screening for sperm donors is very similar, in so much as that they're screened for all general medical problems, but they also have an extensive panel of screening for recessive conditions. They'd also have a chromosome test to establish that they have normal chromosomes, because a small percentage of the population carry a rearrangement of their chromosomes. And also they have a sperm test which determines their quality, etc. Now, we do accept some sperm donors whose sperm count isn't quite as good, because we know that although their sperm count's probably not suitable for insemination, it will be suitable for IVF, or IVF with ICSI, which is where we inject the sperm into the egg. So from that perspective, we gratefully accept most donors unless they have significant past history, and sometimes they can still be accepted as long as we disclose that to the recipients. For instance, we all have wonky or unusual genes, and it wouldn't be uncommon for us to uncover that, but given it's a recessive gene, it means that the recipient must also have that gene in order to have a child that's abnormal. So as long as we disclose that and we screen the recipient for that, that doesn't pose any increased risk to their offspring. So that's how a donor is screened. And the other really important issue is they must consent to future identification. So, and that's made a lot of people very hesitant to donate sperm. The fact that they could be discovered when the child gets to 18 years of age, it does concern some people. But the reality of life nowadays is a lot of people will find out their biological parents on the basis of websites such as Ancestry.com, where people are posting their DNA. And although it may not be the donor that posts their DNA, a sister or an uncle or an aunt, it can often lead to a genetic linkage where they can ultimately track down who the biological parent is. Because, and again, that would concern a number of potential donors. So what that means is that it means we've had to look towards overseas donor banks to try and build our sources. And most commonly, we now use a number of sperm banks within the United States. Obviously, with the COVID crisis, that's been a little more awkward, but still, we're still getting some shipments in from overseas banks. But at any one time, there's a paucity sperm. In the southern states, there's often a long wait for donor sperm. We don't have that long a wait as long as the appropriate donor is there for your use. So what would happen is if you wanted to use donor sperm, we'd set up a triad of appointments between one of the nurses to explain the process. You'd also see a counsellor who'd explain the implications of being a single parent or a same-sex parent when you might inform the child that they've conceived with donor sperm, and what are the ramifications of that child and what they feel and what they desire. And a lot of these concerns about finding out their biological parents has been raised by the children that have been conceived with donor sperm, and that's why that's now a fairly firm rule that children have that right. So with the use of donor sperm, it can be utilised in one of two ways. It can be utilised for insemination, which is the easiest of all treatments. But given now the cost of sperm, particularly the American sperm, is so expensive, a few cycles of insemination are probably equivalent to one cycle of IVF. And there are some distinct advantages to using IVF in that one vial of sperm can be used to create a number of embryos, which gives you a number of opportunities for pregnancy. And probably more importantly, it gives you a greater opportunity for sibling extension. So in other words, having more than one child with the one donor. Because if you reserve, say, 2 vials of sperm and you fall pregnant with the second cycle of insemination, if you then want a second child in a couple of years' time, if there's no further of that donor about, then you would need to look for another donor, and therefore it would have a different biological father, and that may be important to you. So IVF does allow you the luxury of creating a number of embryos to extend your family. There is strict rules again around sperm donation and how many families can be conceived. And of course, in the collection of same-sex couples, often both partners are keen to have a child, and so it's important they reserve sufficient sperm to allow that to happen, although there are limits around that as they go. So I thought I'd just answer a few questions now, then we can move on to some other topics, because I'm sure you... the first question refers to, as an embryo donor, am I able to know the outcome of the donation or meet the children born of my donation? Again, in Queensland particularly, you can either be a known embryo donor, and some people wish to know the recipients of the embryo that you're donating. Indeed, in some southern states, the actual embryo donor decides who the recipient is, and sometimes that through forums can be the case as well. But I have to say, more often than not, most embryo donors are anonymous. They undergo counselling and understand the implications of that. And whilst we can certainly tell them the outcome of the donation, most people don't have any concerns with that. In terms of meeting the children that were born of the donation, again, that's up to the intended parents and the child. But again, they must consent to future identification when that child reaches 18 years of age, when they're mature enough to make all the decisions that they have. So I hope that answers that question. There's also a question around what's involved in the screening process of becoming an egg donor. Egg donor I'll talk about a little bit if we have time, but obviously the younger you are, the greater the chance of pregnancy for the recipient. So typically in Australia, because again it's an altruistic act, there's no commercial transaction that occurs, typically it's people that have had children. Typically people would then be in their early 30s, and they still afford the recipients of those eggs an excellent prospect of pregnancy. So they must undergo counselling, understand the implications of what they're doing. They again must also consent to future identification when the child reaches 18 years of age. And they would have an infectious screen as well, and they would have an exhaustive family history and medical history as well, and that would indeed be passed on. Also, as part of that workup, they would also have a test of their ovarian reserve, which we'd usually do in the form of an AMH or an anti-Mullerian hormone, and it gives us an idea of how well they'll stimulate and what sort of egg donor they'd therefore be. So from that perspective, that process usually involves seeing a fertility specialist to assess all those parameters and to also explain all the process that's involved, because unlike sperm donors, the act of producing the sperm is quite simple. An egg donor needs to go through all the process that most women undergo with IVF. So they need to undergo a 10 to 12 day period of stimulation, followed by a fairly minor operation to retrieve the eggs. But nonetheless, there is an imposition on their life in terms of taking drugs, having some time off work for monitoring and scanning, and indeed a small procedure, which is usually done under an anaesthetic. Obviously, at all times, we're conscious of the fact that we don't want to injure or harm the egg donor in any way, and it's a very gracious act that they do. So from that perspective, if we think they're at too high a risk of ovarian hyperstimulation, or we don't think they're going to respond well enough, then we may not choose to use them as an egg donor. I have to say, in current day, historically, most donors in the past were anonymous. Nowadays, more commonly, they're known. So they're known to the recipient. So these are people that the recipient themselves have recruited, and so they're willing to take aboard some of the lower egg reserve, etc., or some family history that's a little bit adverse because they've specifically gone to these people and asked them. So they're sometimes work colleagues or relatives, nieces, sisters is a common one. The other aspects of finding egg donors sometimes lies with forums. There are numerous forums throughout Australia that look at egg donation, and people often meet, a bit like internet dating, in heterosexual couples to get to know each other online and then perhaps meet in person and decide whether they're suitable or not. The other ones, of course, are going overseas for egg donation, which is fraught with a lot more concern. And of course, the majority of people that go overseas can't do so at the current time, although I did see a lady today that was able to go overseas, and she's got a permit to go overseas, but she'll of course have to quarantine, and that'll be a great financial hardship. Not only is the cost of IVF, the cost of quarantine when she comes back to Australia. There's been another question about, can an anonymous sperm donor opt to find out whether a child is conceived for the donation? Yes, they can. They don't get any identifying details, but they can certainly find out how many children were conceived. In some states, they have the right to find out who that child is, but in Queensland, that's not the case currently. And so from that perspective, the child may approach them when they're 18 years of age. But they can certainly find out from the sperm donor people at any one stage how many pregnancies are conceived. All pregnancies are conceived with donor sperm are quite tightly correlated again, because we need to make sure we don't extend the family limit from that particular donor. So please ask any questions again. No, there's no such thing as a ridiculous question in terms of asking, but as I said before, make them simple. So there's a good question here about providing advice on how to maximise the success of embryo implantation for a surrogate, and if there are greater risks of failure involved, for example, immune-related issues. It's a good question, but it's a difficult one to answer, because obviously we're often dealing with very limited. What's happened here? Sorry, they're starting to pop up on the screen now. Sorry, just. So often there's very limited genetic material, so often people only have a limited number of embryos to use in a surrogate. But you've got to bear in mind that success with an embryo transfer, particularly in a surrogate, is a function of the quality of the embryo and the quality of the environment we're putting it into. Now, given that the vast majority of surrogates have had pregnancies before, it's less likely they've got factors within the uterus such as immunorejection or fibroids or polyps or severe endometriosis, or any of the factors that we might consider when people that have recurrent IVF failure. So our main focus is on the embryo, and there has been an increasing trend, and I'm not sure that it's necessarily a good one for a whole host of reasons, but a lot of intended parents now are genetically testing the embryos to minimise the number of transfers that a surrogate has to go through, which is a good thing from the point of view of the surrogate, and also minimise the chance of them having an abnormal child in terms of having to go through a miscarriage or possibly even worse, a termination. So from that point of view, that's something that people are looking at, but at the end of the day, embryos are what they are. It's not increasing the chance of pregnancy, it just might shorten the time to pregnancy and certainly exclude unnecessary treatments. Given again, under the Surrogacy Act, there is no Medicare permissible for the transfer of embryos into a surrogate. So it does prove to be an extensive process if you have a lot of embryos to put in the surrogate, and genetic screening does offer some advantage in that regard. So I hope that answers that question. In terms of using immune-related issues, I think that's a very controversial topic in itself, and how much a role it plays. But again, we're dealing with people that have usually had children. So, and sure, there can be a mismatch between the intended parent's embryo and the surrogate, but that's open for a great debate. And you've got to also temper that with the fact that you don't want to put through the surrogate through unnecessary procedures for one, but also you don't want to do exhaustive investigations as well that may have some risks as well. So simple things like doing a hysteroscopy, for instance, has some tangible risks of an anaesthetic, and so I hope that's answered that. So do young women with diminished ovarian reserve often have to get donor eggs? I guess that's not an uncommon reason. The egg donation, I guess, falls into lots of categories. There are some women that go through a premature menopause, so are born with a limited number of eggs, and they exhaust that egg source very quickly in their life, in their early 20s or in their early 30s. And I guess we also see the next step down from that, where people have diminished ovarian reserves, and that has significant implications because if they're infertile, they often have a limited ability to respond to our drugs in terms of producing large numbers of embryos. So it's not an absolute reason for using donor eggs, and certainly we persevere for some time, because you've got to bear in mind, if you're young, even though you may have lesser eggs, they're likely to have higher quality than someone in their 40s, for instance, who may also have lesser eggs, but their lesser eggs are more likely to be abnormal than someone in their early 30s. What age do you think it is best to use donor eggs, and why? Again, I think it depends on the situation. And interesting enough, as you're probably aware, the success of a pregnancy is related to the age of the egg at the time of conception. So you could put a donor egg from a 25-year-old into a 45-year-old lady, and her chance of pregnancy would be equivalent roughly to the 25-year-old. So it's the eggs that age, it's not the uterus that age. So from that perspective, it's more about the age of the egg that does it. Now, if you are young, obviously being a young parent has something to be said for it, but I'm not too worried about what age people put their hand up for egg donation. So if it's someone that's had exhaustive IVF and not been able to fall pregnant and they're now 39, they haven't wrecked their chances if they were to use a donor that was younger. And sometimes it's that change in genetic material that makes the difference. What's your view on natural cycle for surrogates? Some fertility specialists like to use a lot of hormones, and others feel it unnecessary as they are surrogates because they are fertile. It's a very good question. I guess there's two facets to that. One is that I always offer people to do it in natural cycles, or you can do it in a stimulated cycle if you don't have regular ovulation, or we can do it in a hormone treated cycle, usually with tablets rather than injections. And there's no real difference in success between them. There are some theoretical advantages to using a natural cycle or a stimulated cycle, and the production of ovulation may have slightly better neonatal outcomes. But I think that's up to what the surrogate wants to do. Unfortunately, within QFG at the moment, we're in a situation where we're still working at limited capacity, and a lot of the days are booked out. So in a natural cycle, you'd normally replace the embryo 5 days after ovulation. So if in fact that day is booked out, because we've run it as a natural cycle, then sometimes that embryo can't proceed with being transferred. And that's why I guess there's a slight move towards using hormone replacement therapy. But yes, we'd like to minimise what drug impact there is on the surrogate, because they are doing it out of the goodness of their heart, and all these drugs do have some side effects. There's a question about age cutoff for egg donors. As I said before, the real success with egg donors lies with the younger the donor, the greater the chance. Now, there are many opportunities where we use older donors, for instance, in sisters. You know, if one sister's 41 and the other's 39, and the egg donor wants to donate, in that situation, we would allow that, in the knowledge that their success rate would be lower. But if we're dealing with anonymous donors, ideally we'd like them to be less than 35. But the question specifically asks about 36-year-olds, 37-year-olds with 6 previous pregnancy. I wouldn't see any obvious objection to that in a non-donor capacity. So there's not an absolute limit there. There is a question about screening for embryos with PGS, and as I mentioned before, that's becoming an increasing trend both overseas and in Australia, just to try and minimise that impact on the surrogate of an unwanted termination or a miscarriage, or indeed having to go through a lot of transfers. But you just need to bear in mind that that doesn't increase the overall chance of pregnancy, it just shortens your time to pregnancy and probably lessens the because it doesn't make the embryos any better. And in fact, it may slightly reduce your chance of pregnancy because it's an invasive process testing the embryo. Do frozen or fresh embryos have better success? That's a good question. Unfortunately, with surrogates, whilst we can use fresh eggs, all sperm needs to be quarantined for 3 months. Now, so in the context of traditional surrogacy, where we're just inseminating the surrogate, that sperm needs to be frozen and quarantined for 3 months before we're able to use it in that context. And that's all really just about minimising the impact of an infectious disease on the surrogate. In the context of using fresh embryos, again, that is possible, but again, the sperm needs to be quarantined for 3 months before it's put into that. So in other words, we have to freeze the sperm in advance of creating the embryo. So I guess more traditionally, we would use frozen embryos. How many unsuccessful IVF cycles before you would recommend donor eggs for a woman in her 40s? Again, it really does depend on the circumstance. There's no doubt that using an egg donor with someone in their 40s does afford them a higher chance of pregnancy than they'd achieve themselves. So I guess it depends on how well they stimulate and what the quality of those embryos are like. There's a question around gender selection for the embryos. Unfortunately, in Australia, that's illegal. We can do it in medical conditions that have a genetic predisposition. So in other words, you know, if you have a condition that's linked to the X chromosome, where it's more common in girls than boys, then we can gender select that. But for the simple selection of a male or a female where there's no medical reason, that is not allowed in Australia currently. There are lots of pressure to perhaps allow gender balancing rather than sex selection, where, you know, if you've had 2 or 3 boys and you'd like a girl, but currently that is not legalised. Now, I'm conscious of the time. We're up to 34 minutes or so. I'm happy to keep on taking questions. Happy to keep on talking if people would like to me to touch on any other issues. Perhaps the thing that we haven't touched on is the use of donor embryos, and that's often an easier route to home. It does mean that the embryo is nothing biologically of the couple, the intended couple, or the recipient couple. These are usually embryos that are created in excess of their needs. So, for instance, people might have 2 children from their cohort and not wish to have any more children, and they're happy to donate the embryos. Unfortunately, most people are not willing to donate their embryos because they're full siblings to their own children. So you can understand their apprehension about having full siblings to their own children wandering about. So from that point of view, they are hard to come by. They do occur from time to time. We do have a waiting list, which doesn't get a lot of traction or a lot of movement, but nonetheless, that is possible. They're counselled in the same way. The people donating the embryos are counselled about what the future implications are. And equally, the recipients have to go through a counselling process as well. All the usual infectious screens that screen for genetic history are all undertaken as well. Often there are only a limited number of embryos, so there's often only 1, 2, or 3 embryos. So it does give them a limited chance, and they essentially go through like a frozen embryo transfer. And again, as I've reiterated before, there can be no commercial transactions that occur in any of these scenarios. But again, most embryo donation occurs anonymously as opposed to known, although there are people from time to time that are willing to donate their embryo to a friend or whatever. We're happy to oblige for that. Has anyone got any more questions at all there? With that, then, if there is no more burning questions, sorry, there's been a couple of ones there. Let's have a quick look at what they are. If frozen embryos are then thawed and tested for genetic screening and then refrozen, does this damage the embryo? I guess there's many schools of thought in that. Certainly at QFG we do it, and we've had reasonable success with embryos that have been thawed and refrozen for a whole multitude of reasons. I guess after genetic testing, then where we've got to take a small piece out of the embryo, it does limit their ability to be refrozen again. But having said that, I have some experience with that, and it doesn't seem to knock around the pregnancy rate terribly much at all. In an ideal sense, we do it in a fresh cycle where they don't have to be thawed, frozen, and thawed again. So there's a question about non-Caucasian couples in Australia who are looking for donor eggs and embryos. I guess the same options that apply to Caucasians, in so much as that at any one time there are certainly different racial groups that are willing to donate their embryos. Obviously, some racial groups don't believe in donating gametes or embryos, but there's certainly many groups of women that are willing to donate from different backgrounds, and at any one time we'll have a different and of course you could always find your own donor in terms of a friend, a relative, online forums, etc. But I guess the biggest number of women that find it difficult to finding a donor in Australia will go overseas, and there are some interesting legal scenarios about that. There is also the option, which I didn't touch on before, that there are some overseas egg donation groups that allow the donors to come to Australia. It's the most expensive option, where you would pay for their trip to Australia, where they donate eggs in Australia, so you get to know who they are. Because one of the problems with egg donation overseas is the eggs must remain overseas, because usually they're paid. These donors are altruistically, although you are paying for their accommodation and their full cycle in Australia. But that's another avenue apart from going overseas. So there's a question about, does genetic testing occur after embryos have been frozen or in the 5-day blastocyst phase? So ideally, we used to biopsy on day 3. Nowadays, almost 100% of the time we biopsy on day 5. And ideally, we do it, as I said before, in a fresh cycle, although they can be done on frozen embryos. There's a very difficult but good question is, how do you find a surrogate? Unfortunately, in Australia, there's very strict regulations around advertising for surrogates. Again, there are forums where people congregate that are willing to be a surrogate, and also people can find their surrogate there. And there are organisations like Surrogacy Australia that have many meetings throughout the year where they not only are sharing information about surrogates and what the options are available, but it's also an opportunity for potential surrogates and potential intended parents to meet. And I've seen quite a number of surrogates that have met their intended parents in that manner. And often they forge a beautiful relationship, and these people are wonderful people, as I said before. So I hope that answers that question in a roundabout sort of way. So I guess while I'm seeing if there's any other further questions come in, what I've talked about tonight hopefully have given you some overview of the scenario. They're very complex scenarios, and there are lots of rules and regulations. But as you can probably understand, it's a decision that's very difficult for lots of couples to make. And we try and guide them through that process with exhausting all their own options to use their own gametes to conceive or their own uterus to carry in the pregnancy. So these are people that have gone through quite a journey, and from that point of view, there are complex psychological issues. So that the issues of counselling and the legal ramifications are so important for these couples. So it's not to be done lightly. And these are very costly processes as well, because they often involve a third person that needs to have a treatment as well as their own. So I hope you've enjoyed that evening. I'm very happy to discuss them further at any point in the future. I can easily be contacted through the Queensland Fertility Group 1800 number or my offices directly. I hope people have had a good evening. Thank you. At that point, I might bring it to an end. And I wish you all a happy night and hope you're all remaining safe. Thank you very much.